Now, there are three layers of palliative care. Now, this is the people who are telling that palliative care is for only dying patients. They should know there are three phases in palliative care. Now, for the dying patients, the palliative care component is called terminal care. That is for the dying patient, yes, right? So those patients having they have days or hours to live, so they need psychosocial, spiritual care. Intensively, you should manage the symptoms. They don't need intensive care. You need high dependency care. You need admissions, right? Um, and usually these patients, I mean, if you have hospices, yes, that is the best place. But if patient requests they need to be at home, then we should be able to manage them at home. But at the moment in Sri Lanka, unfortunately, we can't do this because we have tried several times to do this, but to give a comprehensive care, we are trying for this, but we are unable to provide the terminal care at home because the morphine infusions, midazolam infusions, giving at home, we have some obstacles, even though the pilot project has been done successfully completed, but we haven't implemented this yet to the community in a large scale. So this is the terminal care part. But in other words, we can provide this in any hospital where there are beds. So we can admit this patient and provide the terminal care or in these hospitals. I mean, the best place in Sri Lanka is most of the rural hospitals we can utilize for this purpose, where the bed occupancy is less. So we can spare the beds in tertiary care centers for curative treatment, and we can use other hospitals for terminal care, which is more cost effective, and it is very easy because they are closer to the patient's homes. So end of life care is where patient is having weeks to months to live. So it is very clearly you need to understand when patient is having more than days, that is weeks to months, so their palliative care part is called end of life care. So these patients maybe not they are not curative, so they can be the support can be given in their home setting, hospice, even OPDs, outpatient wise, and even inpatient wise. So sometimes, very rarely, if patient can live for 6 months, 7 months, sometimes palliative surgeries also may be given very selectively. Palliative radiotherapy can be given very selectively for pain management. For example, from bone metastasis, to relieve the bone pain, you can give a palliative dose of radiotherapy. Sometimes, very, very rarely, you can give a palliative chemotherapy to relieve the symptom. This is not to control the disease. This is to relieve the symptoms. So if there are no symptoms, so then, I mean, this is directed treatment, even palliative wise, not applicable. So maximizing community hospice support. So the physical, social, spiritual, psychological support has to be given maximally. So this is the second part, end of life care. Now, what is this general palliative care with any prognosis? Any prognosis at the time of diagnosis, you need to introduce this part of the part of palliative care to patients who are diagnosed with life-threatening illnesses. So maximizing quality of life, this will control the symptoms, and it will help the ongoing medical treatments. For example, investigations, which some investigations may be very painful. So most of the treatments are very painful. So a patient will get some support to continue those treatment with less suffering. Those sufferings can be relieved by the palliative care. For example, chemotherapy. If a patient getting chemotherapy, so the sufferings could be fatigue, vomiting, body aches, depression, um, uh, insomnia, loss of appetite. So palliative care can help those patients. So very important. If you don't provide palliative care at these settings, you will get a lot of drop-offs. Patients will get defaulted. They default the treatment. So they will end up in curative stage, even though if they have got the treatment properly, they would have ended up in a curative stage. So adding palliative care to curative treatment will give a good impact on overall survival and disease-free survival. So these are the three layers. So it is very important to understand general palliative care, end-of-life care, and terminal care. Now, surviving the totality of the patient's existence. Now, we know the physical burden is huge. There are a lot of trials done in palliative care clinics, palliative care hospices, palliative care hospitals and hospices. They have studied these patients are having lot of sufferings. It could be physical, it could be psychological, it can be social, spiritual, it may be many of them. So in a study, they have seen 89% of patients coming to their clinics have pain, 69% having fatigue, 66% weakness, 66% anorexia. So patients with advanced illnesses carry a heavy, often underreported burden. Now, all these things, if you ask them, if you inquire them whether they have this, they will explore, they will disclose these symptoms. But if you don't ask them, they may not tell you whether they are suffering or not. So there is never nothing more we can do. Remember, never ever tell a patient, we can't do anything now. Nothing can be done. So those words should not be told to those patients, because genuine holistic care counters the despair of medical abandonment by simultaneously treating the physical, psychological, social, and spiritual dimensions of the suffering. So pain relief, for example, for physical suffering, anxiety, depression relief from for psychological aspect, family, financial constraints, social aspect, spiritual, meaning of life, existence, distresses, why me, why I am getting these things. So all these things has to be addressed. You need to listen to the patient, allow them to express their worries and suffering, disclose their suffering, and build up the confidence for the patient and the family members to talk to the clinician. So allow them to do that. Then only you can explore the burden. How big is the burden these patients are undergoing, suffering due to their life-limiting illnesses. Otherwise, you think they don't have pain, they don't have fatigue, they don't have any problem. They are nicely getting the treatment. So it is not so. The reality is they have a lot of sufferings. Now, the global reality, a crisis of untreated suffering. What is the estimate? Now, 20 million people requiring palliative care in the final year of their lives. Final year is somewhat you call end of life situation. So 20 million people need palliative care, end of life care in their last year of their life, right? Uh, Out of them, 78% of them are living in low and middle income countries like ours, right? And for children, if you get children, 98% of them are living in third world countries. But unfortunately, out of these 20 million, only 14% of them actually getting the end of life care who actually receive. Getting this end of life care. So estimated fraction of people needed end of life care who actually receive it is 14%. How low it is. It's a, it's a shame for the human kind. Now, to understand how is this palliative care provision in a country, there are certain measurements. The access base in essential pain relief. It is estimated by the morphine consumption, milligram per capita. Now, if you get Sri Lanka or most of these low middle income countries, right? Sri Lankan morphine equivalent consumption is 0.8 milligram per capita. Now you can compare these with developed world. right? USA 60.9 milligram per capita, Denmark 83.4 milligram per capita, Canada 117.7 milligram per capita, Australia 213.4 milligram per capita. Are they misusing morphine or other opioids? Are they using? Are all these people are drug addicts? No. These estimates are for medical use. These estimates are for medical use, right? So you can compare the global north with low middle income countries. How 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 low we are in that situation? How bad, the worst situation we are experiencing. Access to inexpensive, essential medicines like oral morphine remains a critical global health equity failure, leaving millions to die in agonizing, preventable pain. Now, as a clinician, just talk to yourself and say, ask whether my patients are dying in pain. You might say, no, none of them are dying in pain. All my patients are dying without pain. The reason is most of your patients you discharge when they are having pain without giving proper pain medication. Without giving proper pain medication. So you don't see them shouting in pain. You don't see them. The reason is they are not admitted in your ward. They are in the community. They are in the community. At one time, uh, uh, I was asked when I was doing my Trenco clinic, I was asked to see a patient by a MOIC Pulmude. He requested me, sir, can you please come and see this patient? She's in Pulmude. We cannot mobilize her. She's suffering from breast cancer. So I said, okay. At the end of the clinic, I went to Pulmude from Trincomalee, which is 80 kilometers from Trincomalee. So I went to see this patient. Before entering to their land, I could hear the screaming voice of that female, that mother. She was shouting in pain, enormous pain. So, as clinicians, are we seeing these things? Are we hearing these things? No, we don't. We don't. Unless I mean, I think sometimes the community healthcare team may be seeing these things. So we are seeing only the tip of the iceberg, right? But the major problem is hidden inside the society. So I had to prescribe morphine, but unfortunately it was not available in Pulmude, the rural hospital. So I have to ask the CP in Trincomalee Hospital to issue morphine. I had to ask my medical officer to prescribe it. So then they have issued morphine. Patient was pain-free during her last 4 days. After 4 days, she has passed away due to the metastatic breast cancer. So how many of these patients, how many of patients like these breast cancer patients dying in the community without a proper pain relief? So we are responsible. All the clinicians are responsible for this, not identifying the need of pain relief. Now in Sri Lanka, we have a very pathetic situation. Our medical officers are not allowed to decide and prescribe morphine, even though, I mean, that is a big barrier. Now, I have asked this from an Australian palliative care consultant whether your medical officers, after MBBS qualification, whether they can decide on prescribing morphine. The answer was if your medical officer with an MBBS qualification can't prescribe morphine on their own, they are not qualified to have an MBBS degree. That was the answer. Every medical officer every medical student qualified by getting an MBBS degree are qualified to prescribe morphine in Australia. I don't know whether there are different human beings are living in Australia compared to Sri Lanka. But unfortunately, in Sri Lanka or other third world countries, uh, our medical officers, they cannot decide on this. I don't know the reason. Uh, so that may be one reason why our morphine consumption is very low. That is why most of our patients are dying in pain in the community. So we need to find a solution for this. And the Ministry of Health asked me to prepare an estimate for morphine, annual estimate. I have used a WHO calculation formula to get this morphine calculation, but I use only the requirement for cancer deaths, not for other patients who need palliative care. Only I use the cancer deaths in 2022. So the calculation revealed that we need about 94 kilograms, actually 94 kilograms of morphine equivalent per year to relieve only the pain due to cancer deaths. Pain due to cancer deaths. So the real need may be about 200 kilograms per year, right? But do you know 2027, our estimate is 50 kilograms, which is very low. So that means many more patients will die in pain in this country who are suffering from life-limiting illnesses. So we need to take action. Otherwise, the next victim, may be a clinician. I have seen many clinicians dying in pain. It may be an administrator in the health ministry, maybe a director, maybe a provincial director, or maybe a higher rank person. I have seen many of them are dying in pain without proper pain management, right? This is not only for the normal people, even for us. So if we think about us, at least some amount of selfishness. If I am dying, I need to have some morphine to relieve my pain. If I am dying from a life-threatening illness, for example, cancer, do I get morphine? Can I get morphine for my pain relief? So that is a question. The quality of death index is another measurement. How infrastructure dictates the end of life. Now, ideal model is there are 5 components to consider. One is palliative and healthcare environment. Other one is community engagement for end of life care or palliative care. Quality of care, quality of palliative care, affordable of care, whether that will be affordable, human resources available to provide palliative care. So the best palliative care will be available in United Kingdom. So they are ranking number 1. That is this is the ideal setup, and this is what United Kingdom has. So high sources of affordability and quality. You can see they are reaching the high end. Human resources, affordability, and the quality of care little less here. Ideal state compared to the ideal state little less. Community engagement, they also need to improve little bit. Palliative and healthcare environment little bit more. They need to improve. But the national strategy is specially designed to empower dying out of hospital and at home. So they are actually promoting patients dying out of hospital, dying at home. So for that, they need to have a community team to provide the terminal care for dying patients. So this is the ideal state, and this is the United Kingdom situation. So what is our situation? Reality of the gap. See the white area in this diagram. See the gap. Now here we are comparing again a third world country with Sri Lanka. Kenya ranks 63 in quality of death index, but Sri Lanka stands 65. We have our state is 60. Situation is 65, even below Kenya. So you can see the affordability of care Human resources, very less. Palliative and healthcare environment, very less. Community engagement, very less. Quality of care, very less. So if you want to develop palliative care structure, we have to focus on all these aspects. Human resources, yes, educational programs, the doctors, nurses, pharmacies, physiotherapists, and all these, components. I mean, there are a lot of people involved in palliative care. We don't have palliative care consultants in Sri Lanka. My belief is until we introduce palliative care consultants, specialty, the development of this field is very slow. So until such time, palliative care service provision is not only limited to palliative care consultants, all the clinicians has a responsibility. So we need to educate ourselves and provide this care. So we can drag this line as much as possible to this level. Palliative and healthcare environment. Our healthcare system has identified the palliative care as is a very important component. That is the fourth component of the health structure. But still, there's a big gap. So the environment is not conducive for palliative care provision. So we need to improve this. So we need to identify places where we can provide palliative care clinics, inwards beds for palliative care. We have to increase the number and the environment. So community engagement, this is very important. Even though the clinicians, the hospital system, healthcare system providing palliative care, if the community is not involved, we may not be able to provide palliative care. They should accept palliative care as a service and they should engage. They can provide palliative care. They have a big role. So we need to educate them to improve this, drag this line up to this level, like in UK, right? And quality of care. Quality of care. To improve the quality of care, there should be a lot of training and understanding and attitude changing. Those things are needed to improve the quality of care, right? And affordability, of course, the cost should be very less for this. Actually, to provide palliative care, you don't need to spend a lot of money. It can be provided with minimum amount of cost. So services are in infancy, not even childhood. It is in infancy in Sri Lanka. Despite high need, for example, 80% of cancer deaths in Sri Lanka require pain relief. Limited availability, vertical integration, and lack of trained specialists drag overall quality scores down. So we need to find answers. As clinicians, we all are responsible for this downfall, for this low quality service. I will tell you one example, the human cost of inaction and the power of intervention. So this is a lady, Eileen. Eileen is a foreigner. Actually, her sister married to a Sri Lankan Tamil gentleman who lived in Batticaloa. When I was working in Batticaloa, she first presented to me with a lung cancer. She was a heavy smoker. Even at that time, with the diagnosis, she was smoking, and she didn't want to quit smoking. She was very stubborn lady, and she said, "No, I don't need any treatment. Just control my pain. I will die. I will die of this disease." So she initially she didn't have any pain. I didn't give even a I didn't have to give even a paracetamol tablet for her. But with the progression of disease, paracetamol changed into Panadine, Panadine changed into Tramadol, Tramadol changed into morphine, and her terminal part, when she was in the last few days, her morphine dose was oral morphine 60 milligram every 4 hourly with pregabalin 30 milligram 12 hourly. So depending on the pain, I had to go zero pain medication up to morphine 60 milligram 4 hourly. So you have to focus here. Morphine is given 4 hourly, not 6 hourly, not 8 hourly. Immediate release morphine is given 4 hourly. But if you go to clinics, if you ask the pharmacies, whether your clinicians are requesting morphine for hourly. Most of the pharmacists will tell no, maybe 3 times a day, maybe 6 hourly. So which is wrong, because morphine, if the patient's renal functions are okay, morphine therapeutic level will retain, therapeutic level will be there in the body for 4 hours. So if you ask the patient after giving oral morphine, at what time your pain is coming back, if you are not giving morphine 4 hourly, they will exactly tell after 4 hours I will get the pain. Most of the patients are telling me this. I mean, I'm not lying. This is the reality, right? So never give morphine 6 hourly or 8 hourly if patient's renal functions and the liver functions are normal. I mean, they may be impaired slightly, still you can give, but you can assess whether patient is getting overdose or not. Or indication for overdose is drowsiness. First indication is drowsiness. If you ignore that only, then patient will go to the respiratory failure. Otherwise, they don't go to respiratory failure. So the fear of respiratory failure or fear of addiction. I mean, patients are not get addiction if you are giving a correct dose for the patient's pain. That is a fact, right? So untreated suffering quickly impairs quality of life, limit functions, and cause profound demoralization. Therefore, I mean, this is a good example. She passed away peacefully at home. Uh, Actually, I got a huge letter from the family members, thanking letter. This is only part of it, right? I have edited it according to this slide. I mean, so they were very thankful when I mean when there is someone to listen to them and help them during when they are really need the professional help for them. Systemic solutions, the public health umbrella. So the policy integrating palliative care into national health plans and funding models already done. Already done. This is happening for many years now. Drug availability, reforming importation, quotas, distribution, and prescribing laws for essential opiates. The laws and things all are implemented. 1 month supply of morphine for a patient is allowed by the Ministry of Health, but still less prescriptions. Fear of morphine, even by clinicians, I have to tell. Even some of the clinicians are still afraid of prescribing morphine, which is a shame, right? So uh, drug availability is there, but again, it is not in adequate amounts. Why adequate amounts are not available? Because we are not using them properly. So traditional estimates are calculated according to the previous year usage, which is wrong. That is why we should calculate according to WHO formulas, where we are using very low amount of morphine equivalents. So we have to change this very quickly. Education, integrating curricula for professionals and providing family caregiver training. So the Ministry of Health Sri Lanka has started this. So they are educating healthcare staff as well as general public. They are doing a lot of programs for this. It is very important to integrate palliative care into curricula, nursing diploma curriculum, nursing degrees curriculum, and MBBS curriculum, postgraduate curriculum. It is very important to integrate palliative care into all these curriculum. Any medical officer passing out should know how to deliver palliative care. And the general public also should know. Nurses should know, pharmacists should know their part, nurses should know their part, physiotherapists and all the stakeholders should know them. And the administrators, healthcare administrators also should know their part. It is very important. So implementation, developing strategic infrastructure, community leaders, and standardized clinical guidelines. All these things are now happening. All these things are now happening, but it is very difficult to understand why still palliative care is at infancy in our country. Something wrong somewhere. We need to identify that and clear that. I think the best physician is the one who has the providence to tell the patient, according to his knowledge, the present situation of the patient, what has happened before patient comes to you, what has happened, and what is going to happen in the future to the patient and the family and the caregiver. If you can explain this, uh, explain the patient and the family members with the permission of the patient up to now what has happened, what is happening now, and what is going to happen after this moment. It is very important. That is Hippocrates saying. So palliative care is not the abandonment of medicine. Remember, it's not giving up. It's never giving up. It is the fulfillment of its oldest promise. This is the promise. So, in summary, this is the WHO definition. Palliative care is an approach that improves the quality of life. It is the improvement of the quality of life whom the patients and their families and the caregivers facing the problems associated with life-threatening illnesses through the prevention and relief of suffering. You are not waiting till the problems comes. If you can prevent, you prevent it. And if you can't prevent it, if it has come, you relieve it by early identification. Early identification. You don't wait till it becomes chronic. You identify early and impeccable assessment. You have to assess it at the beginning and continuously you have to do it to see whether your intervention has worked or not, whether you need to change assessment and treatment of pain and other problems. It can be physical, it can be psychological, it can be social, and it can be spiritual. So this is the definition you need to remember and adhere to. So the basic principles, palliative care, as a summary, provides relief from pain and other distressing symptoms. So it is applicable at the beginning of the life-threatening illnesses, during treatment, during investigations. All these processes are painful. So a lot of sufferings are there. So you have to provide that. Affirm life and regard dying as a normal process when it is happening irreversibly due to the life-threatening illness. So this is a patient in a hospice. You can see his friend, the pet dog, is coming to see him to say goodbye to his loving one. So these things are allowed. Imagine in our hospital settings, can we do this? This is the quality. This is the quality, right? This is what we should achieve, right? This is what we should achieve. This is not an ICU. This is a hospice, right? Palliative care intends neither to hasten nor postpone death, right? We are not planning to postpone death by putting the patient to ICU. It is anyway not going to postpone, right? Palliative care is to relieve the suffering, not to hasten or postpone death. But good palliative care, we know that it can prolong the life with good quality. I have shown you the study. Palliative care integrates the psychosocial, psychological, and spiritual aspects of the patient care, right? And palliative care offers a support system to help patients live as actively as possible until death, right? So these things are taught in palliative care. How to make your patient, how to support your patient to live actively as possible life. And palliative care offers a support system to help the family cope during the patient's illness and in their own bereavement part during the illness and the bereavement period. So palliative care team, they should help. They are helping. Palliative care uses a team approach to address the needs of patients and their families. It's not an individual person's work. It's a team work. There is a palliative care consultant, palliative care nurse specialist, palliative care pharmacist, physiotherapist, counselor, uh, social service officer, right? And the volunteers, a lot of people are there involved in palliative care. So the whole team will get together and they have a plan and they execute the plan for the to relieve the sufferings of the patient and the family. Palliative care will enhance quality of life and may also positively influence the cause of illness. I have given the example before, right? Overall survival has improved with good quality in metastatic lung cancer patients. Thank you very much. That's the end of the lecture today.